Bismillah wassalatu wassalamu ala Rasulullah. This is an introduction to glomerulonephritis by Dr. Rami Al-Bakr. Shall we start? Okay. Our purpose of this introduction or this session is just to change our current situation from confusing about glomerulonephritis to make this very lovely smile in your face when you have a patient with glomerulonephritis. So its purpose is not to be afraid of the glomerulonephritis. السلايد دي بس هتبقى بالعربي. الهدف من الموضوع ده فعلا ان احنا نهتم قوي بموضوع نشر العلم. اول ايات نزلت من القرآن نزلت اقرأ باسم ربك الذي خلق، خلق الإنسان من علق، اقرأ وربك الأكرم الذي علم بالقلم علم الإنسان ما لم يعلم. وفي أحاديث كتير قوي عن العلم ونشر العلم. ومن سئل عن علم فكتمه ألجمه الله بلجام من النار يوم القيامة. فنرجو من الناس كلها إن هي تحاول تساعد بعضها ونساعد على نشر العلم عشان تبقى الأمور أسهل إن شاء الله على الجميع. The best way for teaching medicine, as we see in this picture, consists of 4 steps. The first step is demonstration, in which the teacher is just doing the procedure and the student is observing. After this, the step of deconstruction, in which the teacher starts to educate or just say what he is doing, where he will put the stethoscope, what he will listening, blah blah blah, and the student is just listening. The third step is the comprehensive stage, in which the student started to say what he will hear or what he will do, and the teacher is just doing the procedure. The fourth step is performance, is in which the student started to perform the procedure and the teacher is just observer. As you see, teaching or education needs some help. The white coat, as you see, is not white anymore. It's full of dust, full of exertion, full of stress. So please, kindly try to help your colleagues. There is a study did in 2022 for how long does it take to become a doctor, and it's very strange. To be an independent physician nowadays, you need more than 14 years. It's a very huge duration. We do a lot of duty. We suffer from a lot of stress. So kindly, please help your colleagues. Nephrologist, when you are working as a nephrologist, you need help. You need advice. You need support. When you are talking about glomerulonephritis, if you are a young colleague, you will hear us talking about this case, and you are listening to us as we say, give him some of this red material, this blue material. So you think it's just a matter of randomization, which is not true. The truth is, the nephrologist is a wise person. He chose the right drug in the right time. This is the really important thing in our duty. This to be able to do this, you need to be educated. You need some advice. I was taught by a great professor, which is Dr. Tariq Fayyad. This is my mentor, my ideal person. He taught me a lot in my life. So it's not about mixing a lot of medications. It's about wisdom. This is the 3 part of our today session, which is consist of part 1 about kidney, and this is the pathology part. Second part about the patient, and third part about investigations and how to deal with it as a physician. Let's start by pathology. To do a kidney biopsy, we need a needle, which is usually 16 gauge. After doing a kidney biopsy, you should observe for the glomerulus, as we see. Then we take the core and divide it into 3 parts. Part 1 is for light microscopy, and part 2 for electron microscopy, and part 3 for histochemistry and immunofluorescence. I need to stress on 3 things in this slide. Number 1, the type of preserver for each one. The histopathology for light microscopy and immunohistochemistry, it's a formalin. But for electron microscopy, it's not formalin. It's according to each lab. Some labs used glutaraldehyde, and some others use another materials. So this is my advice. If you have a patient need to do an electron microscopy for him, ask the lab about the preserver for the sample, because it's not formalin. So it's usually after contact the pathology lab, he will tell you the material or the substance used in its preservation, and he will send you a special tube for electron microscopy. So it's not the usual tube. It's a specific tube. It's a specific preserver. Contact your pathology lab, and he will tell you what's the material, what is the substance used in his lab for electron microscopy preservation. This is number 1. Number 2, I need to focus about what is the difference between immunohistochemistry and immunofluorescence. Of course, immunofluorescence is the old module or old methods in which we use the fresh sample and to be examined by fluorescence dye, which give you the famous green color. This is an old method, not used nowadays. Most of labs use immunohistochemistry. What is the meaning of immunohistochemistry? Immunohistochemistry, it's use a paraffin section. So the sample is not fresh. It's preserved in paraffin, which is shama. So the sample can survive for a longer duration and can be examined even by after years of taking the sample. This is an advantage. But on the other hand, you may lose some finding during paraffining the sample. So if you remember in transplantation, we was talking about if you have a C4D positive in immunohistochemistry, any positive in immunohistochemistry in microscopy, it means it's very strong positive. Why? Because the sample is paraffin. So if there is a still positive C4D after paraffin the sample, this means it's before paraffin it was very positive. On the other hand, in immunofluorescent, it's fresh sample. So if you have finding in the immunohistochemistry, it may be doubtful. It's just a small positivity, but it's positive because it's fresh sample. So this is 2 important things you should remember. The difference between immunofluorescent and immunohistochemistry. Immunofluorescent, it's a fresh sample giving a green dye. The immunohistochemistry, it's a paraffin and giving you the yellow copper-like in color. So it's better to do immunohistochemistry because you can use the sample after years for re-examination by another pathologist to take another opinion. This is a big advantage. If you decide to do an electron microscopy for your patient, you should contact your lab before doing the sample because the sample is not preserved in formalin. It's preserved in multiple preserver according to each sample, which is usually used is glutaraldehyde. Okay. Biopsy adequacy. How to diagnose that this biopsy is adequate? First of all, we should have cortex and medulla, and we should have two cores from different sites. As we see, some diseases are patchy lesions. Patchy lesions which affect some parts and another parts will be completely normal. So if you get a biopsy from a single site, so then it's normal. You will be a little bit confused because you just take a small piece of the kidney, not the whole kidney. Is this the picture of the whole kidney, or just I took the nice place and the kidney, the other part of the kidney is affected? So please, two cores, two different sites. Okay. Then you should look to the number of the glomeruli. One glomeruli in electrode is enough. 5 to 3 glomeruli for immunofluorescent or immunohistochemistry is enough. In native kidney, you need more than 6 glomeruli. In the native kidney, in transplant kidney, you need at least 10 glomeruli and 2 arteries, as we see, because to diagnose vascular rejection or severe T-cell mediated rejection, you need arteritis. So if you miss the artery, you may miss the diagnosis. Stains for light microscope. This is a very important slide. You should remember it very well. We have 5 basic stains for light microscopy. The first stain is hemidextrin and eosine, which is usually called A and E. This is the basic morphology, which is giving you the red color as you see, very light red color. The next dye is periodic acid Schiff. The periodic acid Schiff is dark red in color, as you see in this line. And sometimes you now able to diagnose because you are doing some sort of comparison between the light and the dark red. But if you get confused, you should look to the basement membrane. The periodic acid Schiff adherent to the basement membrane. The basement membrane takes the dye, so it will be drawn like it's drawn by a pen in periodic acid Schiff. In hemidextrin and eosine, the basement membrane is not drawn by a pen, as we will see in the next slides. The next stain is mesamine silver stain, which is the black stain for the basement membrane. It's a very easy stain and to the point. If you see a silver stain or black color over the glomerulus, you should say this is a silver stain, and you should look for the basement membrane because this is the best dye for drawing the basement membrane. The trichrome stain, which is giving you this light blue color, this is the stain for fibrosis. If you see this stain, this means that there is a fibrosis in the sample and it's exposed by this trichrome. The final stain is the Congo red, which is giving you the apple green appearance after under the polarized light, and this is specific for amyloidosis. So we have 5 stains. Just remember it in your mind: hemidextrin and eosine, periodic acid Schiff, this is for basement membrane and deposits. Mesamine silver stain, it's for basement membrane. Trichrome stain for fibrosis. Congo red, which is giving you the apple green appearance under polarized light for amyloidosis. Now we have some sort of some definitions we should know. In pathology, when we are talking about a glomerular fibrosis, we will say glomerulosclerosis. This means we have a fibrosis in the glomerulus. If we are talking about interstitial fibrosis, it will be interstitial fibrosis. But if we are talking about vascular fibrosis, it will be called hyalinosis. So sclerosis equal fibrosis equal hyalinosis. The three terms just related to the site. When we are talking about the glomerulus, it will be sclerosis. Interstitium, it will be fibrosis. When you are talking about the vascular, it will be hyalinosis. Classification of the glomerular disease. This is the normal glomerulus. This is a global disease affecting the whole glomerulus. And this is a segmental disease affecting just a small segment of the glomerulus. When we are talking about distribution of the disease, this is a normal. We have diffuse disease. Just remember, when we are talking about single glomerulus, it will be global or segmental. When we are talking about the distribution of the disease over the whole glomeruli, so distribution, diffuse distribution, it will be a diffuse, D for D. Diffuse means affects the whole distribution of the glomerulus, and focal, it will be related to a focal lesions which is affecting a small number of glomeruli. So we have a disease called focal segmental glomerulosclerosis. This means we have a disease called a glomerulosclerosis, and not all the glomeruli will be affected. It will be a few numbers of glomeruli, and there is another glomeruli will be completely normal, and the disease will not affect the whole glomerulus. It will be affect a segment of this glomerulus. Okay. Now we need to know the whole compartment. We need to comment on how, if we are talking about histopathology. We have this full compartment we need to focus on. The first compartment is the glomerulus, and this is it. This is the glomerulus, and we have the tubules, which is distributed. This is the tubules, and we have the vascular, which is the peritubular capillary, and the capillaries inside the glomerulus, and also the arteries, and we have the interstitium. This is the four compartment we will need to comment on in each pathology. This is the normal glomerulus. We have here an afferent, which is receive blood from the circulation, and the blood enter to the glomerulus, forming the capillary, which is met the visceral epithelial layer, and which is called the podocytes, and start to form the filtration barrier, which is just filter the specific substance to form the urine. There is urine here, which is continue to the tubules to be excreted outside the body. Then the blood get out from the glomerulus through the efferent. We have here, this is the distal tubule. This is the distal tubule. We have here a specific epithelium, which is called macula densa. Macula densa is just an epithelium, which is located in the distal tubule. You just remember this in your mind very carefully. Macula densa is just an epithelium. Epithelium, specific epithelium, which is have a specific function. It's capable of secretion of renin. It's responsible for tubuloglomerular feedback and the regulation of sodium. So it's just a epithelium in the distal tubule. And to get the whole picture again, we have here the glomerulus, blood, and the urine. Simple. Again, this is the glomerulus. We have here blood. This is the afferent. Blood enter. Urine form in the Bowman's space. enters to the tubules. To just imagine how the distal tubule came in beside to the glomerulus. This is the normal anatomy. We have the glomerulus, proximal completed tubule, lobe of Henle, and distal tubule. And this is epithelial of macula densa. Again, to just imagine, afferent blood entered to the capillary, blood filtered, forming urine in this Bowman's space. This is the macula densa. This is the mesangium. I need to just focus in this picture. This is the mesangium. What is meaning of mesangium? This is just substance, and some cells have specific role. Its function is skeleton for the capillary. So it's just a supportive material. It have to support the capillary in its side and keeping the capillary fixed, and usually it consists of the mesangial substance and mesangial cells. These cells, if you count it, it's around 4 cells in each portion. This is a normal mesangial count, mesangial cells count. So you should look to the mesangial number of cells. If it's normal, it will be just 3 or 4 cells, and if it's mesangial proliferation, there will be a lot of cells, more than 4 cells. Okay. Again, afferent blood, urine, and the efferent, and we have the counter current multiplier, and there is exchange between the tubules and the blood, which is result in urine at the end. This is the normal low power field light microscopy, in which we see here the glomerulus. This is glomerulus, our renal corpuscle. Okay, this is blood vessels, and this is tubules and the interstitium. So we have interstitium, tubules, capillaries, and renal corpuscles or glomerulus, and here is a blood vessels. This is the normal shape of low power field light microscopy. Here is some tips for the next slides. We have few questions you need to answer before commenting on any slides. Where are you? This is a very important question. We have sometimes very great mistakes in exams, or when we are thinking about a disease, you are looking to a tubules and you are thinking what is the lesion in the glomerulus. This is a very huge mistake. So before answering any questions, you should ask yourself a very simple question. What is this? What are you looking at? So if you can distinguish a glomerulus, will be a glomerulus disease. You should comment on the glomerulus. But if you don't have a glomerulus and just looking at tubules, please don't mix it up. Okay. Second question you should ask yourself about is the type of stain. This will help you because stain is specific for a finding. So the pathologist will send you some pictures of some lesions and it's exposed by specific stain. So if you know the stain, it will help you to diagnose the lesion. Number 3, don't rush up, just go step by step and try to comment in each compartment, as we mentioned: glomerulus, tubules, and vascular and interstitium. Finally, you should exercise, because reading pathology is not easy, and you should do a lot of exercise reading a pathologist without report, and try to read the report and fix yourself and get more knowledge. So here's the step. We need, number 1, to know where are you. Number 2, you should know the stain. Number 3, should go step by step. Number 4, you need to exercise. Okay, shall we start? Okay, let's start. We have here 5 components of the normal glomerulus. We have normal glomerulus. What is the component? Some components are cellular, and others are non-cellular. The cellular component is the endothelium, the epithelium, and the mesangial cells. So we have the endothelium, which is related to capillary, the epithelium, and we have 2 types of epithelium. We have the visceral epithelial cells, which is the podocytes, and we have the parietal epithelial cells, which is the other layer surrounding the Bowman's space. We have the mesangial cells, and as we mentioned, it's 3 to 4 cells. Let's say just supporting cells for the capillaries. And we have non-cellular component, which is the capillary basement membrane, which is the actual filter. And we have the mesangial, which is just a material just supporting the capillary in its place. This is the normal. You should know the normal to diagnose the abnormal. Where are you? What is the type of stain? Okay. This is the main component. We have the glomerulus, which is you need to comment on, which is we will comment on the cellularity. If there is extracellularity intraglomerulus or extraglomerulus or pulse. Number 2, it will comment on the extracellular matrix. If there is a sclerosis, and sometimes we get confusing of what is called sclerosis. Sclerosis mean this. This mean no cells. If you have a mesangium contain no cells, this mean we have a mesangial sclerosis. Mesangial sclerosis, okay. Peripheral basement membrane, which is the basement membrane thickening or splitting, and the mesangial space, if there is abnormality in the mesangial space. Bowman's space, you should comment on the Bowman's space. Finally, you should comment on the tubules and the vascular to complete the 4 components as we mentioned before. Otherwise, you should look to the interstitium. So, again, glomerulus, you need to look at the cellularity and the matrix and the basement membrane. And finally, you should look to the Bowman's space. After you finish the Bowman's space and cellularity and the matrix and the mesangial space, you should look at the tubules and the blood vessels and the interstitium. The 4 components. Okay, shall we start? This is the first picture we have. First step, where we are. We are in, this is a glomerulus, this is a tubules. What is the type of stain? This is a light red in color, and this is blue colors here of the nucleus. This is the hematexon, and you see. So, shall we start? Okay, we have here the capillaries is opened. There is no cellularity, hypercellularity inside the capillary. Excellent. We have no hypercellularity in the mesangium. We have always 4 cells in the mesangium. Excellent. Do we have a thickening of the basement membrane? There is a thickening, any abnormality in the basement membrane? To be honest, it's very difficult to comment. Firstly, it's hematexon, and you see it gave you no clear picture of the basement membrane, so it's very difficult to comment, but I think it's normal. So the basement membrane is almost normal, but to be honest, it's very difficult to comment. As we mentioned, this is an hematexon and UC stain, which is difficultly you can distinguish the abnormality in the basement membrane. We have also no abnormality in the mesangium. We have normal basement, normal Bowman's space. So we have here a normal glomerulus. Okay. Here we go. We have another picture. Here we have also first step, just look and find out where you are. We have here a glomerulus. We are looking in the glomerulus. This is a first question. What is the type of dye? This is also hemidexin and eosin stain. This is maybe darker in color, as we mentioned before. You should you now are comparing, but as long as the dye didn't, the basement membrane didn't take the dye, you are talking about hemidexin and eosin stain. There is a hypercellularity in the glomerulus. This is so it's hypercellularity. We have here no ability to comment on the basement membrane, and we have no abnormality in the Bowman's space. So just hypercellularity in the glomerulus. Okay. What we are found here. This is what is the type of dye. This is also hemidexin and eosin. As we see, there is no the basement membrane didn't take the dye. So it's hemidexin and eosin, and what is the lesion here? If you just look, there is 1, 2, 3, 4, 5, 6, 7. There is a lot of cells in the mesangium. This is only mesangial hypercellularity. The Bowman's space is completely free, and we have no ability to comment on the basement membrane, because as we are talking about the hemidexin and eosin. And this is what is this? This is an RPC. This is a blood. This is the capillary, contain blood. The capillary is not completely opened because the mesangial proliferation just compressed the capillary, and there is a blood cells RPCs in the capillary. This is normal RPCs. This is not a disease, but the disease here is just the mesangial proliferation, which is compressing the capillaries. Okay. As we mentioned, the basement membrane is very difficult to comment because it's hemidexin and eosin stain. Next slide. Yeah, here we go. What is the type of dye and where we are? We are in a glomerulus. What is the type of dye? This is a periodic SHF. How do you know? This is a basement membrane. As you see, it's drawn like it's we have a red pen, and we have marked the basement membrane. Even the tubules, the basement membrane is drawn by a red pen. So it's very easy. Also, this dye not only taken by the basement membrane, but the deposits, the mesangial deposits, take the dye. So you have a very red mesangium. So this mesangium is filled with cells. So it's a mesangial proliferation. It's not sclerosis. How do you know? I know this because there is a lot of cells. Sclerosis mean this. So if you have a mesangial sclerosis, it will be no cells in the mesangium. Also, to be sure, you need to do a trichrome blue stain. If you have a trichrome, you will see this part will be a blue if there is a fibrosis. But usually, as long as we are talking about sclerosis means no cells. If you have proliferation means a lot of cells. And we have, as we mentioned, mesangial proliferation, it means more than 4 cells. So we have just mesangial proliferation. The capillary is completely normal. There is no hypercellularity in the capillaries. There's just the hypercellularity outside the capillaries in the mesangium. The basement membrane is not thickened. The basement membrane is not thickened, and the Bowman's space is free, not contain any cells. Okay. This is just mesangial proliferation. And what is the type of dye? It's a periodic SHF. Again, we have a periodic SHF, which is drawing the basement membrane very nicely. We have here, this is a glomerulus. What happened to the glomerulus? The glomerulus has been displaced. This is the glomerulus. This is the capillary just closed. This is the glomerulus. What happened? The Bowman's space is filled with cells. This is a lot of cells filling the Bowman's space. So this patient mostly have no urine. He's anuric. Why? Because we have no filtration. The capillaries is compressed. The capillary is closed, and the Bowman's space, which is usually contains the urine, which will be passed to the tubules, is not free. It's filled with cells, which is maybe dead cells or actual living cells. This is the cellular crescent. This is what occurs in fibroid necrosis or rapidly progressive glomerulonephritis, which is crescentic GN. We have cells in the Bowman's space, and the presentation of this patient will be rapidly progressive glomerulonephritis. Okay, what is this? This is a very nice picture of silver stain. As we see, there is a black color. The basement membrane takes this black color and very nicely drawn. This is a silver stain. What is the lesion of this picture? We have, this is a glomerulus, and the glomerulus was shifted or displaced by cells which is filling the Bowman's space. If there is any abnormality in the basement membrane, you can nicely comment on the basement membrane, because silver stain are the best stain for the basement membrane. There is no abnormality in the basement membrane, but it's just displaced the capillary and the glomerulus, and because the Bowman's space are filled with cells. Okay, what is the type of dye, and what we are looking at? What is the type of dye? This is a periodic SHF. How do you know? The basement membrane takes the dye. What happened in this basement membrane? The basement membrane is thickened, and we have also some sort of mesangial proliferation here. As we see, there is a mesangial proliferation, and there is thickening of the basement membrane. Okay, we have here a membranous nephropathy. Membranous nephropathy means thickening of the basement membrane, and it's usually seen by silver stain, a periodic SHF, and associated with some sort of mesangial proliferation. Okay, what we are having here, we have a sclerosis. How did you know? We have no cells. The glomerulus are drawn by hematoxylin and eosinophils. This is the type of dye, and we have here a glomerulus almost to contain no cells and no capillaries. This is a glomerulosclerosis. Okay, what is the type of dye? This is silver stain. What are you looking in? I'm looking to a glomerulus. Okay, what is the lesion? There is a spikes thickening for glomerulus membrane, glomerulus basement membrane. This is a membranous nephropathy. Okay. We just finished the glomerulus. Now it's time to start to assess the tubules. We have two types of lesions affecting tubules. We have acute lesions, which include necrosis and vacuolization, and we have two chronic lesions, which is atrophy and COSTS. As we discussed before, at first you should say, what are you looking at? I'm looking at now, it's tubules. There is no glomerulus at all at this picture. We have tubules. Tubules contain endothelium, this dead cells. Also, we have this tubule containing dead cells and tuberous inside its lumen. This is the typical presentation of acute tubular necrosis in light microscopy. What is the type of stain? It's a hematoxylin and eosine stain, as we mentioned, because the basement membrane didn't take the dye. Again, what are you looking at? I'm looking at tubules. There is no glomerulus at the picture. What is the type of stain? This is an periodic SHF stain. Yes, true. Because the basement membrane now are taking the dye. This is a necrosis. What is a type of lesion? This is a typical presentation of vacuolization. As you see, this is vacuoles inside the tubular cells. We have two types of vacuolization. We have microvacuolization and macrovacuolization, and each type had its own reason. But this is not our topic now. You should be familiar of this lesion. It's just vacuolization. Okay. Let's just discuss the chronic lesions. We have tubular atrophy. What is the types of tubular atrophy and what is the presentation of tubular atrophy in pathology? As we see here, this is tubules. What is the type of stain? This is a periodic acid shift stain, as the basement membrane takes a dye. What is the first presentation of tubular atrophy? We have the classic presentation of tubular atrophy, at which the basement membrane of the tubules become very thick, and the lining epithelium of the tubules become very small or flattened. So this is the classic pattern of tubular atrophy. What we have here also, here we have a glomerulus, we have a glomerulus, we have a glomerulus, and the tubules between the glomerulus. What is very significant, and you to catch your eyes, the glomerulus are very close to each other. This is the endocrinization pattern of tubular atrophy, at which tubules become very small and the basement membrane become very thin, and so the tubules become near to each other. This is the endocrinization pattern of tubular atrophy. We have the final presentation here of tubular atrophy, which is at which the tubules become lost its cellular lining, and it filled with fibrin material. So this tubules is not functioning and it's very old and not working. This is called the thyroidization pattern. So we have here three patterns of tubular atrophy. We have the classic pattern in which the basement membrane become thick and the epithelium lining become flat. We have the endocrinization pattern in which the tubules become very small and it become very thin, have a basement membrane very thin, and the glomerulus start to be near to each other. We have the endocrinization pattern, thyroidization pattern, in which the tubules are filled with fibrinous material and lose its epithelial lining. Again, this is, as we see, this is a tubular atrophy. Tubules contain eosinophilic materials, and this is typical presentation of tubular atrophy. This is a typical presentation of fractionated cast, which is related to amyloidosis, which is different from the previous one because this pattern of fraction can we see in the cast. Let's assess the interstitium. We have acute lesion affecting the interstitium, which is including edema and the inflammation, and we have chronic lesions, which is include fibrosis. As we see here, there is a lot of inflammatory cells infiltrate the interstitium, and if we just look here, this is the tubules, the basement membrane taking the dye. So we are talking about the periodic acid shift stain, and the tubules is away from each other. This is not typical, as we see in the previous pictures. Always tubules back to back. So if we have some distance between the tubules, this is an infiltration of edema. There is edema in the interstitium causing tubules getting away from each other. This is typical presentation of interstitial inflammation, and edema. Okay, as we always say, the dye can give you a clue. As we see, this is a trichrome stain, so we are talking about fibrosis because this stain is specific for fibrosis. There is a fibrosis here and there is no cells, so the interstitium takes the dye. This is a typical presentation of interstitial fibrosis. Let's talk about the blood vessels. We have two types of lesions, as we discussed before. We have acute lesions, which include fibroid necrosis and thrombosis, and we have chronic lesions, which include hyalinosis and elastosis. This is the fibrinoid necrosis. Fibroid necrosis is a picture related to vasculitis and typically clinically present by rapidly progressive glomerulonephritis. So it's an autoimmune disease. You will have this inflammation, and you have in the middle the fibrin material closing the artery. This is the typical presentation of fibroid necrosis, and if you see the lesion in the glomerulus, you will find a crescentic GN. So it's a fibrinoid necrosis, autoimmune disease, inflammation, fibrinoid, and crescent in the glomerulus. And the fibrinoid necrosis is completely different from fibrin thrombi, which is occur in disseminated intravascular coagulopathy. As you see here, this is fibrin thrombi. If you just focus, the fibrin thrombi contain not associated with crescentic GN. This is one of the clues which is usually used to differentiate between the fibrin thrombi and fibrinoid necrosis. Also, the fibrinoid necrosis, the fibrin thrombi always affect the whole blood vessels in the glomerulus, in the tubules, peritubular capillaries. So it's a generalized lesion. This is the look of fibrin thrombi in large vessels, and this is the fibrinoid necrosis. As you see, this is just fibrin thrombi without inflammation. This is inflammation. Color, it's difficult to distinguish because you have now the two colors, so you can differentiate. But usually you have not the both picture to comparison. You just look for the crescent. You should look for the inflammatory cells. This is one of the clues to differentiate between fibrinoid necrosis and fibrin thrombi. This is the classic presentation of chronic lesion affecting the blood vessels, at which we can see this lumen is almost completely occluded, and there is a fibrosis in the lumen of the blood vessels. So it's called hyalinosis and elastosis. Let's start to discuss some point in the electron microscopy. We have here the glomerular filtration barrier, which includes the three layers: endothelial layer related to the capillary, basement membrane, and podocyte, which is the visceral epithelial layer. Here we see the slit diaphragm. This is the light microscopy, and this is the electron microscopy. We have here blood, and here we have urine. Again, we have here blood, and we have here urine. This is another picture. We have the blood. I have here the urine, and we have here the mesangium. Here is the mesangium. The most important point when you see a picture related to electron microscopy is to distinguish where is the side of the urine and the side of the blood to diagnose where is the deposits. So you can imagine this is a C-shaped. C-shaped always contain or surrounding the blood. On the other hand, urine is outside the C-shape. This is one of the more classic clues to diagnose where is what are you looking at. Again, as we discussed, this is a C shape. We have here the blood, and this is the podocytes. Okay, as we mentioned, to start to diagnose the pathology, you should ask yourself where are you, what is the type of stain, take it step by step, and try to exercise and try to reading pathology without it. Now it's time to start correlation between the histopathology and the clinical presentation. We have here what is called the epithelial pattern. Epithelial pattern, clinically, it will be presented by massive proteinuria. This is the lesions which is affect the epithelium, which is called the podocytes, including the membranous minimally change, FSGS collapsing, and this is the most common presentation and with diabetes and amyloidosis. This is the most common pattern affecting, causing the massive proteinuria and affecting the epithelium. As you see, the lesion occur here. So the patient will have a massive proteinuria. And this is the clinical presentation. So all of this disease almost will present by the same picture clinically. And if you are in nephrology round and you have a patient have a nephrotic syndrome, you should say it's a epithelial pattern. Most probably, the patient have a lesion affecting the podocytes. So my differential diagnosis will be these lesions. The endothelial pattern, which is include post-streptococcal and vasculitis, usually patient presented with acute kidney injury and maybe up to dialysis. So again, if you have a patient with acute kidney injury and the urine contain active urinary sediment and you're suspecting the endothelial pattern, most probably you will think of these lesions, which is related to the endothelium. The lesion will be here, so the patient will lose a lot of blood in his urine, and he will most probably present with kidney injury and elevated kidney function and azotemia. The mesangial pattern, which is usually present by hematuria and the asymptomatic proteinuria, in which lesion occur here. And this is a typical differential diagnosis, which is include 9 diseases, including the IgA, IgM, diabetic nephropathy, and amyloidosis. These lesions were presented by hematuria and asymptomatic proteinuria, and sometimes causing azotemia by compressing the capillaries. So we have severe deposition or proliferation here. So it will compress the capillaries and causing azotemia. We finished the presentation or the introduction to histopathology, and we now shift to the next stage, which is including the patient presentation. What is called clinical syndrome? What is the meaning of clinical syndromes? Clinical syndromes, as we mentioned, nephrotic syndrome, in which patient present with heavy proteinuria and hyperlipidemia and lipituria and generalized edema. This is called clinical syndrome because it's clinical presentation. But what is the underlying pathology? We don't know. What is the cause? It's primary or secondary? We don't know. So it's a differential diagnosis according to a clinical presentation. This is why it's called clinical syndrome. So we usually have these three typical clinical syndromes and two others, which is include as we will mention in the next slides. We have here nephrotic syndrome, and we have asymptomatic urinary sediment and nephrotic syndrome, and we have the chronic GN and rapidly progressive glomerulonephritis. This is the most common 5 clinical syndromes in nephrology. Again, we have clinical syndromes, which is caused by pathological diagnosis, and the pathological diagnosis has etiology. This is the most common clinical syndromes, as we mentioned: nephrotic, nephritic, asymptomatic urinary sediment, rapidly progressive glomerulonephritis. This is the most common and rapidly progressive. And the pathology is just prescribing the lesion in the pathology, which may include tubular lesion, glomerular lesion, interstitial lesion, and vascular lesion, and the etiology may be primary or secondary. So it's your job as a nephrologist to diagnose the whole spectrum of this diagnosis. Let's give an example. If you have a patient presented by nephrotic syndrome, so you will say that my patient has a nephrotic syndrome, which is including a generalized edema and proteinuria and lipiduria. And most probably this patient will have an glomerular disease, and the glomerular disease will be an epithelial pattern. So you will say it, and you will do a kidney biopsy, which describe a patient have a membranous glomerulonephritis. This is a typical epithelial pattern, which is presented clinically by nephrotic syndrome. The next step is diagnose why this patient has a membranous glomerulonephritis. Is this primary or it's secondary glomerulonephritis? So if you do antiphospholipase A2 receptor antibody in the serum or in the biopsy, in the immunohistochemistry microscopy, and diagnose it as a primary membranous, you now diagnose the whole spectrum, and you should now start your treatment. But if you missed any part of this diagnosis, you will not be able to treat your patient. Again, we have this most common presentation of clinical syndromes like asymptomatic urinary sediment, or if the patient came with microscopic hematuria, nephrotic syndrome, which is include proteinuria, hypoalbuminemia, hyperlipidemia, and generalized edema. Nephrotic syndrome, which is nephritic syndrome, which is include active urinary sediment, and the oliguria, azotemia, and hypertension, and rapidly progressive glomerulonephritis, which is occur very rapidly, and they're usually associated with subnephrotic proteinuria and normal blood pressure. I need to focus on this spectrum, which is usually we exposed to this spectrum in transplantation. If you have a patient presented to you by hypertension and CKD stage 4 or 5, and the patient was diagnosed as a hypertensive induced glomerulosclerosis, this is you should think very wisely before you say this is hypertension glomerulosclerosis, because hypertension in most of cases it's a secondary hypertension related to renal disease. So it started as a glomerulonephritis, and glomerulonephritis caused the azotemia and the renal insufficiency, and the renal insufficiency associated with hypertension. So the patient came to your clinic, or the first visit, you examined or checked his blood pressure and discovered he has hypertension. You not simply say this patient has a hypertensive induced glomerulosclerosis and hypertension is a primary disease. It's usually the opposite. The renal is the primary disease and the hypertension is just secondary. I need to focus in very hard figure, which is hypertension to cause renal insufficiency. It usually need to be 20 years. 20 years average to cause hypertensive glomerulosclerosis. So if you have a patient 25 years old and they came to you with hypertension, don't suspect that the hypertensive glomerulosclerosis. It's very unlikely because he is very young. And the hypertension need 20 years to cause hypertensive glomerulosclerosis. So patient must have hypertension since he was 5 years, which is uncommon. I need to give you a break with there is this very nice video of Will Smith. I hope you enjoy it.
I love this one. Fail early, fail often, fail forward. You know, it's always a little bit frustrating to me when people have a negative relationship with failure. Failure is a massive part of being able to be successful. You have to get comfortable with failure. You have to actually seek failure. Failure is where all of the lessons are. You know, when you go to the gym and you work out, you're actually seeking failure. You want to take your muscles to the point where you get to failure, because that's where the adaptation is. That's where growth is. Successful people fail a lot. They fail a whole lot more than they succeed, but they extract the lessons from the failure and they use that, the energy, and they use the wisdom to come around to the next phase of success. You gotta take a shot. You have to live at the edge of your capabilities. You gotta live where you're almost certain you're gonna fail. That's the reason for practice. Practice is controlled failure. You're getting to your limit, getting to your limit, getting to your limit. You can't lift that, you can't do that, until you get to the point that all of a sudden your body makes the adjustment and then you can do it. Failure actually helps you to recognize the areas where you need to evolve. It's crazy because it's like when you've had a certain amount of success, it seems like it should breed confidence, but it actually doesn't. When you win a lot and you lose the ability to lose, you're not allowed to lose anymore. Right. You actually lose the ability to create. Right? Because the reckless abandon, and it's something I'm getting back from watching my kids, they really don't care. That kind of reckless abandon and that lack of fear and not trying to protect anything and not trying to live up to a legacy or anything. Fear is the killer of creativity, man. And it's like, there's also a misconception about failing, right? It's like, no, you have to fail a lot. You know, you have to fail early, you have to fail often, and you have to fail forward, right?
Okay, let's take just 2 minutes. If you want, stop the playing and take a cup of coffee before proceeding for this next hard topic, which is include some topics about some items about the investigations. We will start now. Here we go. This is the third part of the today's session. We will discuss about investigations and how to comment, how to think about your tools in nephrology. Investigation in nephrology. We have in nephrology laboratory investigation like urine, like serology. We do renal function test, electrolytes, immune screening, and virology. And we have some radiology, and we have a special investigation like kidney biopsy or fundus examination, transplantation, immunology workup, and the EBG. Okay. Let's start by urine investigation. Urine investigation include urine routine, 24-hour urine collection, and bacteriology and cytology. Urine routine including physical examination, chemical examination, and microscopic examination. Physical examination include appearance, odor, and color, specific gravity and osmolarity. Chemical criteria, which is include pH, nitrate test, glycoside esterase, bilirubin, ketones, and glucose and protein and blood. And we will discuss today about some item about proteinuria. And microscopic examination includes cells and cost. This is the usual presentation, which is usually in our routine practice. This is the physical examination and chemical examination, the microscopic examination. Proteinuria. What is the factor affecting proteinuria? Proteinuria is affected by three main factors. Now, number one, the type and characteristics of protein, the size or the charge. The more size and the more negative charge, the less liability for this protein to be lost in the urine. Number two, the permeability of the glomerulus and the filter. Number three is the tubular reabsorption function. I have here a very important information I need to focus in your mind. Normally, there is 1 gram to 3 grams of protein lost in your urine, and this is normally, and it's approximately 2/3 are globulin and 1/3 is albumin. But as you see here, the tubules is able to reabsorb this amount. So if you have a tubular disease, you will lose subnephrotic proteinuria. This is maybe related to the tubules. This is number one. Number two is 90% of this filter are reabsorbed by the tubules, but the final results you will have 150 milligram of protein lost in your urine, and this is normally. So this is the cutoff. It will be accepted in transplanted donor or any patient come to your clinic and they do proteinuria test, and the cutoff is 150, and some takes up to 200 maximum. This protein is called Tamm-Horsford protein or uromedulin, and this is a protein which is acts as a host for cells coming from the glomerulus. So we have Tamm-Horsford protein, which is usually present in our routine daily urine. We have albumin. We have some other protein like immunoglobulin. We need to comment on each one of them. What is available for evaluation of proteinuria? We have single urine sample, which is we will discuss with our patient. We need just one sample in which we can use dipstick test, sulfosalicylic acid, and albumin creatinine protein create ratio. On the other hand, there is another item which is include 24-hour urine collection, which is still the gold standard for evaluation of proteinuria. Also another classification which is include semi-quantitative test. Semi-quantitative test just tell you average if the patient have proteinuria or not, but he can tell you what is the exact amount. This is dipstick and sulfosalicylic acid. And you have quantitative measures which is include 24-hour. This is the gold standard. Protein create, albumin create, and we have what is this new items, albumin excretion rate and protein excretion rate. Let's start by semi-quantitative test. Semi-quantitative test, which is include dipstick and sulfosalicylic acid, is just a screening test. It's easy, so it's screening, but it can't be depended on for evaluation of proteinuria because we have fallacies in this test. If it is abnormal, you should go for quantified this amount. Quantification is very important. Why? Because it's diagnostic. If you have patient who is nephrotic, it's completely different from subnephrotic or microproteinuria. So it's diagnostic. Also, it's prognostic, and it's also used for monitoring of response. So screening, quantify to diagnose all these items. Urine dipstick, as we mentioned before, it's have negativity, false negativity. What is the cause of false negative urine dipstick? Urine dipstick, you have to know two main important. Number one, it's only sensitive for albumin. So if your patient have proteinuria non-albumin, so it will be negative. This is number one. Number two, it's just it's not sensitive. So you need to have macroproteinuria, and this macroproteinuria is mainly albumin to be detected by dipstick. So if you have a patient, let's say diabetic patient, and he has a diabetic nephropathy, he is in early stages, so which is just microproteinuria, dipstick is not the typical or not the ideal method for evaluation of proteinuria in such patient. You should proceed directly to the quantitative methods and do a protein create or albumin create ratio. False positive also we need to focus. Some things do false positive urine dipstick, like which is usually see hematuria or UTI. Pus cells are read as a protein, so it gives you a false positive proteinuria. Also, some drugs like chloride and some medications, some antibiotics, and the iodinated contrast give you a false positive. Again, focus, just read this is albumin, not a protein, as we mentioned, because dipstick is just for albumin. It's not for all the type of protein. Albumin is just subunit of the protein. This is a dipstick. Sulfosalicylic acid is on the opposite. It's detect all proteins. It's very sensitive. Also, if you have a negative dipstick and have positive sulfosalicylic acid, this means your patient have a proteinuria. It's not albumin. It's suggesting myeloma kidney, and you need to exclude it by routine labs to diagnose the myeloma patient. Yeah. Also, it's false positivity related to some drugs as penicillin and also the cross hematuria and the iodinated contrast. This is a typical presentation of sulfosalicylic acid and its average evaluation of the quantity of proteinuria. The quantitative methods, and we will start by 24 hour. 24 hours still the gold standard. 24 hour, the normal amount is this is less than 150, as we mentioned before, milligram per day. Its a major limitation, it's difficulty in collection, and so your patient will not be comfortable when you ask him to collect 24-hour urine for evaluation here of his proteinuria. This is the main issue. Also, some patients collect, but they don't collect correctly. So you should make sure that your patient did it right. So you should multiply 20 or 20 average for male and female, or if it male it may be 25, if female it may be 20 milligram per kg creatinine to evaluate if this patient did the collection right or not. This is in age below 50, because this is the age we have muscle exercise and we have great muscles volume. But under above the age of 50 to 90, the creatinine excretion starts to decrease. So you should multiply 10 milligram per kg to evaluate the accurate evaluation of 24-hour collection. Urine protein creatinine ratio, it's a urine sample. You will ask your patient to do just morning sample. It's valid use valid tool for evaluation or follow up your patient. The main issue here, you should focus on the unit used in this lab, because we have multiple units like milligram per deciliter, like millimole, like milligram per gram, milligram per 24 hour. So if your proteinuria is milligram per deciliter and creatinine concentration is milligram per deciliter, this will give you a picture gram per day or or milligram per gram. So it's equivalent to each other. This is the results equal to the 24-hour unit protein, so there is no conversion. Let's say if your patient have 2 gram, if your patient have protein create ratio, which is equal to milligram per gram, so it's your patient have 2 gram for 24 hour. So it's no need to do any conversion. So milligram per gram, it's equal to gram per 24 hour. But the main issue here, if we have millimole, if you have milligram per millimole, you should simply to convert it to 24 hour, just multiply by 10. It's the accurate figure is 2.2, 8.8, but to simplify the equation, just multiply in 10. So if you have a patient with albumin creatinine ratio 30 milligram per gram, it's 3 milligram per millimole. I hope it's clear. The advantage of using protein create and albumin create is just simple method. You just give the patient a cup of urine, and the morning sample is very good, and it's more than enough. The disadvantage of using this method, it's affected by serum creatinine, because the serum creatinine is the dominator of the ratio. So if you have advanced kidney disease and creatinine excretion is affected, you will suspect the result. This is number one. Number two, it's used morning sample, so it will miss the proteinuria, which is affected by the orthostatic or diurnal variation of proteinuria. So it's just a sample, so you may miss some diagnosis. Also, it's affected by creatinine because it's the dominator of the ratio. Let's have an example here. We have, this is the normal ratios of proteinuria. As you see here, the unit for evaluation is milligram per millimole. So you should multiply this by 10. So let's start from the beginning. If you have, let's say 150 milligram per gram creatinine, is normal. It's normal for proteinuria, because as we mentioned, we have normally 150 milligram or milligram per day proteinuria, which is temhorsifol or uromodulin. If you have a proteinuria more than 150, from 150 to 500 milligram per day, so it's trace proteinuria, which is equivalent to microproteinuria. If you have proteinuria from 500 milligram to 3 grams, this is a macroproteinuria. If you have more than 3,000 milligram per day, this is the nephrotic range proteinuria. So the units is very important. Just to focus on the unit. If it's milligram per millimole, just multiply by 10. Just focus, is it proteinuria or albuminuria? Because this is a big difference. Simply to convert from proteinuria to albuminuria, just subtract the normal proteinuria, which is 150 or almost 200. And there is a multiple equations or calculator to convert from urine protein create to albumin create, but simply again the normal ratio for urine albumin excretion, albumin, not a protein, normal excretion is less than 30 milligram per 24 hour or 30 milligram per gram. This is the same. So they don't get confused, and this is completely different from millimole, which is millimole, just to convert from milligram to millimole, it just divide by 10. This is the normal. Microproteinuria, which is equal from 30 to 300 milligram per 24 hour, which is equal in the proteinuria from 150 to 500. Okay. And finally, we have a significant proteinuria, which is nephrotic range more than a significant proteinuria. This is a macro from more than 300, and the nephrotic range, it will be more than 3,000 milligram per 24 hour. This is again milligram per millimole, just divided by 10. So the normal, it will be below 3. From 3 to 30, it will be microproteinuria, microalbuminuria, and we have overt albuminuria. It will be more than 3 until 300. It will be the nephrotic range. Again, this is the albumin-creatinine ratio by millimole. So 30 milligram per millimole equal to 50 milligram per millimole equal to 0.5 gram per 24 hour. We have another tools which is usually present, it's now available, which is called albumin excretion rate and protein excretion rate. It's just equation to make the protein create ratio more accurate. It's we have here another parameters to be evaluated in the equation, which is included age, sex, and race. Not only the creatinine and the albumin in urine, and it's more correlated to 24 hours than protein create ratio according to the final studies. So the net results we should think about approaching to evaluation and follow-up of proteinuria. Firstly, if you have a patient you're suspecting to have a proteinuria, you should do the 24-hour urine collection and the post-protein create or post-protein create or albumin create with the 24-hour. This is the initial evaluation. Then if there is correlation between them, between the 24-hour and the protein create, you can proceed for monitoring or evaluation of your patient by protein create, which is more simply for the patient, and it's only morning sample. And finally, if you decide to change your medication or alter your therapy, you should again do 24-hour. So follow up protein create and albumin create or protein excretion rate, albumin excretion rate, it's very good tool for follow up. But if you decide just to change your medications or alter your therapy, you should again re-evaluate your patient using the 24-hour unit protein again. We have here that classification of proteinuria. You should know about it. Transient proteinuria, it's related to fever or exercise, and usually it's below 1 gram per day. We have persistent proteinuria, which is including orthostatic proteinuria. Orthostatic proteinuria, it's uncommon to be more than age of 30, and it's usually subnephrotic, 1 gram to 2 gram max, and it can be excluded by doing a split urine collection, as we discussed in the group, or just doing a morning sample after complete rest at night. Overflow proteinuria, which is related to myeloma, it's mostly it can be nephrotic, but it's when you do a urine protein electrophoresis, it's mainly immunoglobulin. So it's not albumin, it's mainly immunoglobulin, and usually variable, but it can be nephrotic range. And as we mentioned, dipstick will be negative, and sulfosalicylic acid, it will be positive. Glomerular proteinuria, it's usually nephrotic range, but it can be subnephrotic. But if you do protein electrophoresis, it will be mainly albumin. Finally, the tubular interstitial, as we mentioned, the tubules is responsible for reabsorption of 90% of the albumin and protein, which is filtered in the tubules. So if you have a tubular disease, it will not be able to reabsorb the proteins, so it will be lost. But tubular proteinuria, it's mainly subnephrotic. It never exceeds nephrotic range, never to exceed nephrotic range. And if you do an protein electrophoresis, urine protein electrophoresis, it will be heterogeneous and of low molecular weight. Post-renal causes like UTI or tumors, and this also it will be less 1 gram. So our typical approach, it will be, if you have a patient coming to your clinic presented with proteinuria, and you need to know what is the kind of proteinuria, first you should repeat the test after 1 week to exclude the transient proteinuria. So firstly, simply repeating the test, you will exclude the transient proteinuria. So if you have patient with persistent proteinuria after repeating it twice, you should firstly exclude orthostatic proteinuria. You should do a split urine collection. After this, you're excluding orthostatic proteinuria, and you start to do quantification. If you have a nephrotic range proteinuria, it's mostly glomerular, but to make sure, you can do a urine protein electrophoresis, and if it's no albumin in nature, so it's 100% sure this is a glomerular. Or if it's associated with another manifestation of glomerular disease like hematuria, COSTS, so it's no need to do a urine protein electrophoresis, it's just glomerular in nature. But if, on the other hand, it's not albumin, or this is not associated with other manifestation of glomerular disease, or dipstick is negative and sulfosalicylic acid is positive, you're most probably facing multiple myeloma. So you should do a urine protein electrophoresis. It will be immunoglobulin in nature, and it will be probably myeloma. If all this was unmatched, and they did a protein electrophoresis, urine protein electrophoresis, and it's supposed to be low molecular weight proteinuria and heterogeneous in nature, it will be tubular disease. So simply repeat the test and do split urine sample for excluding orthostatic, 24-hour or urine protein electrophoresis, and 24-hour to diagnose the amount. If it's a nephrotic range, do a urine protein electrophoresis to diagnose glomerular from multiple myeloma from tubular. We finished the proteinuria, and now we discussed some items about hematuria. You should know this is a picture of dysmorphic RBCs. Dysmorphic RBCs here have finger-like projection, which is called acanthosis, and this is the normal shape of monomorphic. This is dysmorphic, and this is monomorphic RBCs. This is the acanthocytes, which is RBCs squeezed during passing through the glomerulus, so it has like finger-like projections. And we have, this is a biconcave shape of normal RBCs. So again, nephrology investigation include laboratory, radiology, and special investigations, as we discussed before. Let's move to serological investigations. I should just discuss 2 items. Number 1, if you have a patient have serum creatinine 1.5 milligram per deciliter, is this a slight elevation? As we know all, as a nephrologist, the normal range of serum creatinine is up to 1.1 and some labs 1.2 milligram per deciliter. So we have just elevation from 1.2 to 1.5, just 0.3 increase. Is this a slight elevation of the kidney function? I should focus on this point, because if you have a patient of with serum creatinine 1.5, you are lost more than 50% of your kidney power, because this GFR is most probably below 60. So don't take it lightly. And the GFR, as we mentioned, it will be around 49 or something, or 50. So you are losing more than 50% of your kidney function. So it's a very important idea to, when you have a patient with AKI, don't just look to the creatinine. Urine output is usually precedes the creatinine. This is Akin criteria, Reifel criteria for diagnosis of AKI, and this the comparison between urine output and the creatinine. So you should know, creatinine is very late marker. It will start to increase when you are losing more than 50% of your kidney's power. So urine output is usually more accurate in evaluation of our patient, especially in AKI. Finally, I need to discuss about glomerular filtration rate. Glomerular filtration rate, it's usually done or evaluated by measurement or calculation. What is the difference? The measured GFR, we are using the creatinine clearance. We will ask our patient to do a 24-hour urinary collection, and we just use this information to diagnose the creatinine clearance. So it's 24-hour urinary collection. We do the urine creatinine in urine volume subdivided by plasma creatinine multiplied it in 1540. This is what is called measured GFR using creatinine clearance. It's not used in evaluation of donor in kidney transplantation, because it gives you idea about the GFR of the post kidneys. And donor, we usually use the split kidney function using the isotope, which is also one of the methods to evaluate the GFR by measurement. We give the patient isotope, and we follow the excretion of this isotope to evaluate the GFR. So it's measured GFR. We have the gold standard test for evaluation of GFR and the measurement of GFR, which is used by Inulin. Inulin is the gold standard, but it's usually used in research because it's not widely used, and this needs to be hospitalized and infused over solution. So it's not easy to be done, but it has a typical criteria for be used. It's freely filtered, not absorbed, but not secreted. So it's a gold standard, but it's not widely used. Finally, we usually use the estimated, not the measured GFR, in which we use multiple equations like Cockcroft, like MDRD, like CKD epidemiology, and she's used multiple factors of multiple parameters to be measured. Measured versus calculated. Every single test, it has its value. So, for example, MDRD equation is the most widely used in transplantation, in plaque races, in diabetic patient. Cockcroft is preferred in older patient, but still you should do the measurement or the 24-hour urinary collection and the creatinine clearance in such a patient like pregnant woman, like extreme in age, malnourished patient. So every test, it has its specific site to be used. This is calculated, and the measured is including the previous examples. We finished this serology. We will go to renal imaging. This is the most common used imaging for these kidneys. This is not our topic today. Let's start about the special investigations. Fundus examination is a bedside test. It's easy to be done. You should know it. There is a lot of diseases can be diagnosed by fundus examination. like fundus retinopathy, hypertensive retinopathy, Allen-Host, papilledema, Rosa spot. It's very easy. It's a very simple test. You should know how to do it. I was lucky to have this senior of mine in Dawli Hospital. This is Dr. Ahmed Abdullah. I own him a lot, teaching me about the fundus examination using ophthalmoscope. So we are finishing now. So if you have a patient coming to you with deranged kidney function and you need to know, is it acute versus chronic? You should firstly look for the signs of chronicity, like CKD MPD, CKD anemia. Ultrasound, you should look for the size, shape, echogenicity. You should proceed for a special investigation like fundus or biopsy. But what I need to focus to diagnose a glomerular disease versus non-glomerular disease, the glomerular disease is usually associated with nephrotic range proteinuria and the hematuria and the costs, especially RPC's cost, and all of this is just diagnosed by urine analysis. Urine analysis is the main important cornerstone in diagnosis of glomerular disease. So you will never diagnose this patient has a glomerular disease or not without doing urine analysis. And you will not proceed for kidney biopsy except you have a very good explanation to your patient and yourself using urine analysis, which is presented by active urinary sediment, and the patient shows to be acute or chronic disease according to CKD MPD anemia at ultrasound. Our summary today: before biopsy, you should know the provisional diagnosis based on clinical syndrome and investigations. Pathological pattern is just a prescription, it's not a disease. If you have a patient with mesangial proliferation, it's just prescription of a lot of cells in the mesangium. But what is the disease? This is your differential diagnosis. Biopsy to be accurate, it should be 2 cores, 2 different sites, and you should do the 3 microscopy, but at least you should think about the disease before asking for pathology, because if you need to do electron microscopy, you should get the specific preservation, which is most probably glutaraldehyde. Adequate biopsy and type of stains, what is the criteria, types of pathological pattern and its clinical correlation, clinical syndromes, proteinuria, how to evaluate and how to approach a case of proteinuria, measured versus estimated GFR, acute versus chronic, and glomerular versus non-glomerular disease. And we have some just clinical training. This case, 24 years old, male, presented with edema lower limb. So you're suspecting your patient have a nephrotic syndrome. You did a urine analysis, which is give you just proteinuria and have you no RPCs. So you are suspecting you have an epithelial pattern. Creatinine is normal. What is your approach? As you think, this is in this age, you have 3 main diseases, which is FSGS, minimum change, and membranous. So you have serology, you have urine, you have special investigations. Do you do a biopsy or not? Most probably you will do biopsy after collection if it's a nephrotic range, so you will need to diagnose. But according to our differential diagnosis, you will ask your lab for electron microscopy. You will ask for doing antiphospholipase A2 receptor antibody in the biopsy in immunohistochemistry. So it's something you should think for discussing your case with the pathology. And there is a form you should know. You should inform your pathologist by all investigation you did and its results to be able to help you for diagnosis of your case. And thank you.